How cool is that, right?
Yeah. Now, what would you guys say? I feel like this makes perfect sense, the way we're talking. But sometimes when working with new BHCs, they feel uneasy because they're like, I can't really. Oh man, it's almost like they're trying to set up the visit to protect themselves. They're like, well, the reason why I want to tell them that it's not therapy is because I don't really go there with patients. I'm not going to talk about their trauma. And if they want to bring up that, then I'm going to make sure that I get them out of primary care and straight to a therapist. And so it's almost like they're putting these parameters on what they're going to do, not necessarily to inform the patient per se, but more to protect themselves from going down a rabbit hole. Have you guys seen that with training maybe novice BHCs, that they're trying to protect themselves?
I think it's usually just a training issue, you know, that they just need more skills, more clinical interventions, more confidence in their ability to really lean in and help a person with a big problem at that point. And so that's why I think, you know, training goes on for year and a half, because it's a big job. It's a new job. There's a lot of things to learn. So, you know, like the webinars we do to upskill people over time, that kind of confidence comes with really getting the training you need, the support to, well, the information, the context to practice, and the coaching by people that have been doing this for a while over time.
Yeah.
I totally agree with that. I think it is a training issue, and I would add that I also think it's kind of a you know, it's a perspective issue, maybe, in the sense that we've really, I mean, you brought up the example, Bridget, of trauma, right? I mean, yeah, I mean, I see this all the time. We have horribly pathologized trauma in our society. So where, you know, to where we have, I guess, convinced lay people and many in the healthcare community that if you've experienced a traumatic event in your past, it means that you need extended psychotherapeutic, you know, interventions in order to recover from that. And so I think people have this great fear that they're delivering a substandard, you know, level of assistance to patients if they engage on this topic around trauma. And then, you know, the other way that we've pathologized it is kind of through this belief that if you, you know, if you start talking about trauma, then, you know, that's going to be, you know, something that's really painful and potentially harmful for the patient. And it's going to, again, you know, need the promise of many follow-up visits over time there in order to kind of help this wound heal over that you're, you know, reopening or what have you, right? And so, you know, that is really unfortunate, though, because so many patients have trauma in their background that is contributing in some meaningful way to what the patient is coming to see you for on a given day. And if you just kind of skirt over that and you don't, you know, talk to the patient about that, or try to understand how that trauma is influencing their functioning, you know, and the problem that they're coming in to see you for today, then you're probably not going to be providing a very helpful visit for that patient. And worse even yet, potentially you might lead that patient to feel like, you know, you didn't really want to hear it, right? And kind of further pathologize, you know, their trauma, right? So I think it's really scary for BHCs, you know, a lot of times, because they don't have the promise of, you know, 15 more weeks of follow-ups with the patient. You know, it's really scary for them to jump into those topics and try to incorporate that trauma in some meaningful way into what you're doing with the patient. But if you do it, it's hugely rewarding, most of the time. I mean, because these oftentimes are, again, they're often maybe, really, really important pieces of this person's learning history that have shaped how they're, the problem that they're coming in to see you for today. And if you, if you really use that, you can provide a really meaningful intervention for a patient. But if you gloss over it, or worse yet, you kind of tell them they have to go to somebody else to talk about this because of how, apparently sick they are, then you're really doing a disservice and you're missing an opportunity to help the patient.
Well, we've talked a lot about that in other conversations, just the risk of if somebody brings something up, like you said, it might be related to something that happened in the past is related to what's going on now. If you're like, whoa, we can talk about all this other stuff, but we can't talk about that. For that, you're going to need to go elsewhere. That reinforces this idea that maybe we don't want to hear it, and that they're so sick, and that this is so wrong, and this is so bad, and needs so much work that you absolutely can't bring it up to me. You need to go to a completely different building.
And Patti, I know you got thoughts on this, because I mean, this is what you and Kirk are all about this idea of, we can be intentional, we can have radical change with a variety of different things, that it's not surface level stuff, that this is meaningful. What are your thoughts? What's percolating in your mind? I'm really interested in what your mind's going through right now.
Oh, I just think there's so much we can do for people that have gone through traumatic experiences. And I just am so jazzed about behavioral health consultants around the world being there for the people as we progress through the pandemic, and then struggle with all of the issues we're going to be facing post-pandemic. So yeah, lean in and do it. Do whatever you can to help. I know David and Bridget, you've been doing a lot of outreach to people in your clinics, and yeah, there's so much we can do. Acute stress and post-traumatic stress. We've got randomized controlled trials of treating PTSD in primary care in 4 30-minute visits, right, Jeff?
That's true.
Yeah.
Right. And it's funny, because I feel like we could probably talk for hours about this, and just for the sake of the video and the sake of having a functional one that people will watch, we'll maybe pause here. And if Kirk is in the background, Patti, tell him that he needs to suck it up and come on camera. But no, I do want to say one final thing about Patti, something that you often talk about, and I think Bridget and I have been very fortunate about this idea of getting core competency training. And this is where I think a lot of the difficulties that we have with being able to generalize the model and to standardize these things is the training is not standardized. And I think we have different variations in a lot of ways where we'll think. So our gratitude for both of you and Kirk, if he's listening right now, because we have been very fortunate to get that training. And it's great to always talk with you both about just reinforcing it. It just, my mind always goes. So thank you again for being here and being willing to have these discussions.
Yeah, thank you.
Yeah, and thanks for hosting. It's fun.
Awesome. All right. Well, see you all. Thanks for watching.